I think, first of all, it's a very difficult discussion to know when to broach, and I think it's a very difficult discussion to know how to approach. There are a lot of challenges. First of all, you need to be a fairly senior clinician to start off with, to have the insight and the knowledge base to be able to make these kind of decisions. You also need to know the patient and their beliefs, their attitudes, their cultural beliefs, in addition to their medical background. And you also need to allow time for that conversation to happen. So it's not necessarily a conversation that you can go in with your own agenda and say, right, I need to speak about DNACPR today. It's sometimes something that needs to happen over a period of days sometimes, or even weeks.
I always try to remember that sometimes these situations just occur and never to see it as a separate issue. That I try not to have the conversation or put off the conversation, but to listen to the patient, find out what they're thinking and feeling, what their view of the current situation is, and pick up any cues for opportunities that they might be thinking about their condition, or they're worried about the future or about their family. I very much see it as part of the ongoing assessment of the patient, and each opportunity where you meet with the patient, allowing them the time to express themselves and to explore what they're thinking and feeling at that time.
I don't think there's an easy answer, and there is no perfect time. I mean, for everybody it's probably going to be different, and it obviously helps if the doctor, whatever grade they are, knows them fairly well, because the other thing is no idea how people are going to react. But it is a really, really difficult subject to approach, and I do appreciate that. So it is about timing, but as I said, that is very difficult and it's individual.
I don't think there's any one right way to do it, but I think if you prepare for the conversation in as much as you get an environment which you're not going to be disturbed, an environment which the patient is comfortable to talk, and an environment where you've got enough time to be able to have the conversation for as long as it's needed. I think if you start off with that, then you're on a pretty good basis. And then use normal communication skills techniques. So by asking fairly open questions and seeing if the patient will lead me down that track. Have you thought about the future, or are there any aspects of your future treatment which you've been particularly thinking about recently? If you're able to start conversations using the patient to guide you, then I think you can't go far wrong.
So I think the whole thing revolves around timing, privacy, and the patient, the family, having time to think about it, discuss it, before they absolutely make any decisions. And probably also understanding that they can change their minds.
On a personal level, I think that just being human, speaking to the patient on a one-to-one as one person to another, spending time listening to them and helping them express themselves is important. However, for them it really can't get much worse than it is. If the professional is sensitive and empathic towards the patient will appreciate that.
I think no doctor should be forced to have these kind of discussions unless they feel comfortable to have them. And I think the immediate source of help would be always their senior members of their team. There will always be a palliative care team within the hospital, and I'm sure that they would be able to provide advice on how to have sensitive discussions like this. But also consulting the local hospital policy, and also now the All Wales guidance on DNACPR decision making does provide some useful tips on how to have these kind of discussions, and at least how to fill in the forms and document the decisions correctly, especially as these discussions need to then be verified by a senior consultant anyway.
I've seen a huge improvement in the way in which these conversations are held over the years, and many people coming through the system now through medical school see it as part of the ongoing role and of helping patients manage their own future, helping them make informed decisions. And I can understand why some people are still very hesitant about it, but any conversation could be bad news for the patient. So I think it's just about adapting it into your everyday practice and knowing when it's appropriate and when the patient is thinking along those lines, and giving you opportunities to raise the issue with them if they don't raise it directly themselves.